Good afternoon. I'm Dr. Herbert Silverstein, president of the Ear Research Foundation. And today we're going to continue talking about our hearing education series and talk about research opportunities. And I'm joined today with Sierra Goldsmith, who is the head of our research program. This is our building where our foundation is located. And I'm going to let Sierra introduce herself.
Hi, my name is Sierra Goldsmith. I am the Director of Clinical Research here at Ear Research Foundation.
So today we're going to talk about clinical drug trials, clinical device trials, investigator-initiated studies, and inventions.
So first, we're going to talk about clinical drug trials. And how clinical drug trials all start out is with an application for an FDA approval for the trial. Then it goes to phase one. Phase one tests to see if a new treatment is safe and the best way to give the treatment. Phase two looks at efficacy and side effects. Phase three looks at efficacy and adverse reactions. And phase four looks at safety and efficacy. After phase four, it goes on for FDA for approval to join the market. We currently have two clinical trials. The first one is Frequency Therapeutics FX345, which is regenerating cochlea cells for hearing improvement. That is a phase one trial, which is looking to test if a new treatment is safe and the best way to give it. We are also doing the VC100 Oticon bone-anchored hearing system, which is a prospective study on Baha's Ponto implant use after minimally invasive Ponto surgery.
So first, we're going to talk about the results from the regeneration of the cochlear cells. It's not right.
So we'll start off by saying the current study, and then we'll go on to the results. Our current study is a phase 1B prospective randomized single blind controlled study to look at the safety of FX345. And we're looking for adults 18 through 67 with acquired adult onset sensorineural hearing loss. Now, what is adult onset sensorineural hearing loss? That would be anyone with sudden hearing loss or noise-induced hearing loss. With this, there's a chance you'll receive the placebo or a chance you'll receive the actual medication, FX345. Now, that rate is a 2-to-1 rate, so you have 2 out of 3 chances, or a 66% chance to receive the FX345. The total time for the study is 4 months with 8 visits. Along with these visits, you receive $150 per visit, which equals about $1,300, and all travel, lodging, and meals are also paid for, so you can be anywhere in the country and join our study. So to go into those 8 visits specifically, the first visit is a screening visit. We look at your medical history. We do an ECG and labs, such as blood work. You do an audio testing and an exam. That's about 2.5 hours. Visit 2 is a second screening with an audio testing and exam, 1.5 hours. Visit 3, that's going to be your longest day. That's an injection visit. You once again have to do the audio testing, a few questionnaires, ECG, labs, exam, injection, and then we monitor you after to make sure you're feeling all right. That visit is about 5 hours, and the injection itself is only about 45 seconds. Now, these visits 4 through 8, are all follow-up. The 4th visit's about 30 minutes. That's just ECG and labs and an exam just the day after to make sure you're good. Visit 5 is a 15-day follow-up with audio testing, labs, and exam. And then visits 6 through 8 are 30, 60, and 90 days after the injection, where you do, once again, audio testing, questionnaires, and the exam. And those visits are about 1.5 hours.
So now we'll talk about the results of previous studies with this similar drug or the same drug. And so 6 out of the 10 were treated with the FX 322, and 4 out of 10 were treated with the placebo. 4 of the 6 patients that received the medication had statistically significant, meaningful improvement in their hearing. In contrast, no placebo-treated ears showed any changes.
So next, we're going to talk about our study with Oticon, the bone-anchored hearing system. So this study is a prospective multi-study study on the performance of the Ponto implant system using minimally invasive surgery. The total time for this study is 1 year with 7 visits, and for compensation, it's $100 upon completion of all 7 visits. Now, what's nice about this study is that all of the visits are the visits you would normally do with your pre and post-op procedure. So you wouldn't be coming in any additional visits. You would just be coming in for your regular checkups, where we would do a few questionnaires, do a few assessments to make sure the device is sound, to see how you're feeling, and then that's it. So you have a screening visit first, where we get all your medical history and questionnaires. After that, we look at the stability and do an exam. After that, we do some follow-up. And once you're done, that's it. Now we have investigator-initiated studies. Now, these are all studies managed by non-pharmaceutical companies in medicine or academics. It looks at already approved devices and treatment for various indications and analyzes different results with new findings.
So the 2 studies that are initiated by the investigators here was the SAGE cochlear implant performance study and cognitive function, and the micro-WIC with Meniere's disease, a prospective study with transtympanic dexamethasone perfusion treatment using the micro-WIC in patients with Meniere's disease. And we'll discuss this a little further. Okay.
So first, we're going to talk about the SAGE. And what is SAGE? SAGE is a self-administered geocognitive examination. So it's kind of like a test or a little quiz that you take to analyze cognitive function. And so we're looking at the relationship between the cochlear implant performance and cognitive functioning using this SAGE examination. So what's involved? It's pre and post-operation questionnaires during your routine visits, so you don't need to make any additional visits. The results of this study showed that using the SAGE could be used to predict speech outcomes after cochlear implant in older adults. It could also be used to screen adults for mild cognitive delay or dementia before receiving a cochlear implant. Further studies can help provide better preoperative counseling and accurate guidelines for anyone getting a cochlear implant.
So I'm going to talk about the micro-WIC and the results of that use of that device. So in about in the late 90s, I developed this small little wick that we place through the eardrum into the middle ear, and it rests on the round window membrane, which is a thin membrane covering the inner ear. The reason that we developed this wick was to let a patient put medication in their ear that would then travel down the wick into the on the round window and be diffused into the inner ear. This can be used with various types of medication. So we'll talk about one study that we did with this micro-WIC, and we've used this with steroids in the ear and also gentamicin, placing gentamicin in the ear for dizziness. But the exciting thing about this is that we found out that treatment of the inner ear with steroids for a month with this micro-WIC gives our best results, and I'll tell you about that shortly. So what we did was do a pre-operation questionnaire and post-operative questionnaire. And this was during their patients' visits, or we sent them emails and talked to them on the phone. And we found out of our patients, 34 patients, 50% of them reported subjective improvement in their tinnitus, which is one of the only drugs that we know that can reduce tinnitus. And with these patients, of course, they have Meniere's disease and too much pressure in their inner ear. So the steroids act to decrease the pressure and decrease the tinnitus. 59% of them said that the fullness and the stuffiness in their ear was relieved. And 79% said the vertigo was better. Only 21% of the patients had hearing improvement after using the steroids for a month. So using this technique, using the microwick that I developed, is a well-tolerated treatment for patients, and it's a good option for patients with Meniere's disease that are bothered by the symptoms. So the bottom line is that the data suggests that significant efficacy in reducing oral fullness, tinnitus, and vertigo attacks in these patients. And then we started this prospective study, which we're involved in now, to see how these results compare to looking at the previous records. Now I'd like to talk a little bit about the inventions and innovations. So we've had several advancements. One was we've developed a surgery to help patients with hyperacusis, and I'll talk about this in detail in a few minutes, which is the round and oval window reinforcement, the microwick, which I just talked about, Silverstein facial nerve monitor, the laser stamp to restore hearing without prosthesis, vestibular neurectomy through the mastoid to relieve vertigo and Meniere's disease and preserve hearing, and the transosseous spat tube for long-term aeration of the middle ear and the transcochlear eighth nerve section. So this shows the first surgery for hyperacusis, which is noise intolerance. We've operated about 75 patients now with good results in many patients. And what we do is take a little bit of fascia, which is tissue over the muscle right above the ear. And we make little round circles of this fascia that we'll place in the middle ear. And I'll show you that now. So we found that the little stapes bone was hypermobile or jiggled around a little bit too much in the middle ear. And to quiet that down, we packed tissue around the stapes and over the round window membrane. And after doing that, the stapes appeared to move less. And here's another picture of this, putting the tissue in around the stapes and the round window. And so after doing this procedure, the patients have noticed that they can tolerate noise better, and they can assume a more normal life. If the procedure does not work, it does not hurt the ear. It's a minor procedure, and it's worth taking a chance on this procedure because the results are usually good. And if they don't, if it doesn't help the patient, it doesn't make them worse. One of the other things that I developed was the facial nerve monitor to help in the surgery of the ear to protect the facial nerve from injury. And this we developed in 1983, and we're still using this monitor today. And we attach this to the patient's face and use it during surgery. And it's been very helpful in preventing injury to the facial nerve. The next procedure was called the laser stamp procedure, and this is to restore hearing in patients with otosclerosis, where they have minimal fixation of the stapes bone or the third bone of hearing. So this shows you the otosclerosis fixing the stapes here, and this is the laser probe that's used to make some cuts in the stapes so that the stapes will become mobile. Here you can see the cut going across the foot plate here. shows the cut in the anterior cruce here. So the stapes becomes totally mobile after this procedure, and a prosthesis is not needed. We did about 80 patients with this procedure, and the results have been good and held up over the years. Vestibular neurectomy was developed to cure or relieve the vertigo of Meniere's disease and preserve the hearing and preserve the facial nerve. So this is the right ear, and we go into the mastoid bone, remove the mastoid cells, and then we can open up the covering of the brain here and look in with a microscope, and we can see the 8th nerve here. And we cut the vestibular nerve here, preserve the cochlear nerve and the facial nerve. And this is another approach without removing a lot of mastoid cells, going just behind the lateral sinus here and going in. This procedure is quicker than the original surgery and works very well. The transosseous spat tube is used for patients that have chronic serous otitis media and chronic problems with their eustachian tube. And the idea here is to aerate the middle ear on a long-term process. And this to do this, we make a little hole in the bone of the ear canal, and then we put a tube, a silicone tube, in that hole, which is held in by flanges, and that will remain in place for many years. The last procedure is the 8th nerve section through the cochlea. And this is a little confusing, I'm sure, because you can't see all the anatomy here, but this is going through the ear canal. This is the cochlear nerve here, facial nerve, and balance nerve here. And what we do is we cut those to cut the cochlear nerve and the vestibular nerve and preserve the facial nerve. And what that does is relieve the vertigo of patients, and it also reduces their tinnitus. And this is in patients that have very poor hearing in the ear. And in the last few years, or last 20 years, when we found that the cochlear implant could not be used when we cut the cochlear nerve, we stopped doing this procedure. So this is a procedure that was done in the past, but it was very effective in helping the patients. The disadvantages, of course, they can't have their hearing restored.
So if you want to get involved in research, there are 4 different ways. You can email a copy of your latest audiogram or hearing test to info@earrf.org. You can call us at 941-556-4264. You can even mail us your request with our address below, or you can come and visit the foundation, and we would be happy to talk to you about all of our options for research. All right, thank you so much.
All right, thanks very much, and we'll talk to you later.